I guess I'd like to say that people, humans, we've always lived with a dread of infectious disease. From the bubonic plague of Europe to the 1918 flu pandemic to the AIDS epidemic in the 21st century. But I'd say about 7 decades ago, there was kind of a sense of victory. We had new vaccines come along for measles, for polio, for whooping cough, and there was a sense that we were on top of many of these diseases, and what we faced still was heart disease and cancer. But now there is a new concern arising about contagious disease, germ resistance to many drugs and antibiotics, and a measles outbreak more recently. It's caught the headlines. So I'd like to turn to our guests and ask a basic question for each of them. I'll start with Mr. Burnshead. What do you think, what do you consider to be the biggest issue in infectious disease in the area you work in, and why?
Well, I think the biggest issue for us is the constant emergence or reemergence of pathogens that we have to respond in regards to surveillance, investigation, and control. In our time in public health, essentially we've been dealing with, in the last several years, vaccine-preventable disease outbreaks such as recent measles response, also the emergence of Zika virus in Central and South America, and the threat that posed to the United States through travel, as well as Ebola outbreaks in Western Africa, and the risk of travelers returning from those outbreak-affected countries, and going back 10 years to occurrence of pandemic influenza events such as during 2009, 2010. Although the core response is very similar in regards to what we do as far as responding and controlling those infectious diseases, there's always a different situation in regards to the population that's affected and whether or not we have specific control measures such as appropriate antibiotics, if it is a bacterial pathogen, available vaccine, or appropriate control measures to try to limit spread within the population.
Are these of concern to Oklahomans? Some of these seem exotic. We haven't had really an outbreak of Ebola, but do you see that play out in your role at the State Department of Health?
We do. With each of these scenarios that I referenced, they do seem exotic. However, Oklahoma, just like residents of other states, are very mobile, and for either personal or business-related reasons, they may be traveling to areas that are affected by these pathogens, which means that we have the risk for individuals, specifically subgroups of individuals that may be at risk of exposure for traveling to those areas. And so, for example, during Zika virus occurrence in several countries, Central and South America, we did have individuals that were traveling either for leisure purposes or for business purposes. And so we had approximately 30 cases during that time that were identified. And that brought new challenges, not with just confirming the presence of Zika virus as the cause of their illness, but then also assuring that we had reduced the risk of potential transmission locally, like you saw in some states like Florida and along the Texas border. Same thing with Ebola. We had approximately 100 individuals during the Ebola outbreaks affecting Western Africa countries for traveling for various reasons. And those individuals, upon their return, we had to assure that we monitored them for their specific incubation period from their potential exposure to limit the potential occurrence of spread if they were to develop illness. Fortunately, we did not have that occurring as far as anybody that developed illness from Ebola, but there was still a required response because of Oklahomans going to the countries, including responding to those events by being involved with medical care or public health response to monitoring individuals that were specifically affected in those countries.
Thank you. Dr. Cools, in your role as a pediatrician for many years and a specialty in infectious disease, what are your biggest concerns now?
Well, when I came to Oklahoma way back in 1987, the father of pediatrics for Oklahoma, Harris Riley, showed me a box that they used to put kids in to try to ventilate them when they had polio. And to me, I never saw a case of polio. To me, it was, we have that under control. Let's talk about other diseases. I took care of one of the first kids with HIV, with AIDS, that died before we even knew what the virus was. I've watched and had to take kids off of a ventilator for Haemophilus influenza disease, meningitis. And I've watched over my career great treatments for HIV where people are able to live a long life. Most pediatricians today haven't seen a case of Hib because we have a vaccine for it. And now, as my career is ending, I feel very sad and feel very pressing that diseases like measles, which I saw in my young career but never saw a case for 25 years, is coming back. Diagnosed one of the first case back last year in Oklahoma. Diseases that we thought we had under control now are reemerging, because now it's not just a matter of infectious diseases and advancements of science. We have to interplay what's happening with society and social media and everything about vaccines that play a role. And I think that's going to be pressing more and more over time.
Thank you. Dr. White is a clinical pharmacist with OU Medicine. I think of the OU Medical Center. What are your biggest concerns in your area, in the OU medical system?
I think in general for pharmacists and people who work in the hospital, some of the organisms we are concerned about are resistant pathogens, Clostridium difficile, especially gram-negative resistance, extended spectrum beta-lactamase producing organisms, or ESBLs, organisms that are resistant to carbapenems, and really being able to identify those patients quickly and have good treatment options, and especially oral options for those patients.
Thank you. I should note that the facility dealt with one case, I believe, of Candida auris, a fungus that's considered a global health threat. And were you involved in any of those efforts or protocols?
Yeah, I'm involved with infectious disease treatment for all patients, especially resistant organisms at OU Medical Center.
Okay. I'd like to go straight to what patients often think about, just before we get into issues like vaccines or other, and generally drug-resistant germs. There seems to be more fear than ever of getting sick. People are very alarmed about it, whether it's measles, whether it's the flu, or something else. So, and your relationship with your doctor seems to be shifting. And so I want to ask you some really basic questions. You go to the hospital now, and they're like hand sanitizer machines all over the place. You go anywhere, the movie theater. So I don't know, I'll open it to which one of you takes the question. Do hand sanitizers work? Do they really help prevent infections? Should we be using these all the time?
They are safe and effective. When you look at hand sanitizers like alcohol-based hand gels, they're effective as long as they're at least 60% strength alcohol. However, what's important to note is that they're only effective if your hands are not visibly soiled. If your hands are actually dirty with some sort of material, whether that be soil itself or sputum or blood or something like that. Obviously, what's more important is to actually use your core measure of washing your hands, which is with soap and water. But if you do not have easy access to soap and water and you have alcohol-based hand sanitizer with you, then it is certainly effective. It's one of those things that we definitely recommend, especially when we're talking about viral respiratory illness seasons such as influenza. It's a good standard practice to go to, especially if you just don't have ready access to sink and water or water and soap.
Masks. More and more people are wearing masks. You've seen the pictures from Asia where everyone on the street is wearing a mask. And now I went to the doctor not long ago, and I was asked to put on a mask. I'd never been done before. Do masks work? Should we be wearing masks all the time? Dr. Cools, Dr. White, any thoughts? Do these do any good?
I mean, for certain pathogens, like respiratory viruses or influenza, if you're sick or you're around someone who is sick with one of those pathogens, could have some benefit.
I will tell you, though, that when it comes to most respiratory viruses, such as a virus called RSV, which is seen in very young children, there's actually been studies looking at mask versus no mask in the hospitals and looking at rates of infections, and mask alone doesn't do very much. The reason is because the infectivity is not just by going through the nose, but it also can go easily through the eyes. And what happened with a lot of healthcare workers is they have their mask on, they're rubbing their eyes, they don't wash their hands, and they were getting nosocomial infections that way. So that, do they play a role, mask? Maybe a little, but you still got to keep your hands away from your face. And actually what one study showed is that if you wore mask and goggles, that you probably had a better chance of stopping transmission than mask alone.
I'll just add a quick note from Dr. Kuhl's response. When we're talking about public health investigations, it wouldn't be a routine for us to just advise somebody to just wear a mask. Our go-to is to limit your interaction in public settings and try to really reduce the potential overall of actually spreading the specific pathogen of interest if you're infectious. So the message would be stay at home when you're sick, of course. And that's one of our core measures for controlling further disease spread is if you have somebody that is infectious, such as measles, when they're infectious during the 4 days before and 4 days after their rash onset, well, then we essentially isolate them. Particularly that might be at home if they are able to care for themselves, or if they are hospitalized, then they're going to be isolated in an appropriate setting within the hospital setting to try to limit exposure to others. So I definitely agree with Dr. Kuhls that it may be something that is beneficial, but not on its own, and it really could be a very specific focus measure to try to limit further disease spread.
And finally, not to belabor this, but washing your hands. Do you think that message gets out there enough to people? Is that very effective at preventing contagion of disease, flu and other disease?
It's a measure, or it's certainly a message that we try to stress often. I mean, hand hygiene is one of those most important public health measures that you can put into place. It's basic, it's available to everybody. It is effective for many pathogens of interest, those where you might either accidentally spread to others through direct contact or from picking up pathogens through fomites. Hand hygiene is really going to be one of those most effective measures, and it's one that we always include in our messages and cannot stress enough.
Agree with that.
Yeah.
Vaccines. Very non-controversial topic, but I would say there are many good people out there who have doubts, who have convictions about vaccines and their long-term effects, their risks. There's a lot of books and literature and websites, some from very well-respected people, some from people who are very strident. So I'd like to just each of you address briefly, what are your thoughts on whether vaccines work and whether the risks outweigh the benefits? And we'll start with Dr. Kuhls.
Well, that's an easy question. Are vaccines effective? The answer is no doubt. I think I've already mentioned that we've been able to eradicate smallpox. We have polio almost eradicated. Most people have not seen a case of H. flu, meningitis, or epiglottitis. When you look overall at the vaccines that we have, all the vaccines are all very, very effective. When you talk in terms of risk, every vaccine has some kind of side effect. Mostly minimal, usually a little bit of redness from the shot site maybe, or maybe a little bit of fever. Rarely, maybe the fever causes a seizure. So there's always side effects. But you always have to look at the benefit of the vaccine versus the risk of the vaccine. And in every case in the United States with the vaccines that we have required, the benefit far, far, far outweighs any kind of small side effect that there is. And so that's why vaccines are so important, because they're effective and they have very low risk.
Dr. White, what are your thoughts?
I second that. There was a lot of press that came out after Dr. Wakefield published his study in Lancet, which has since been withdrawn with regards to autism, and multiple studies have shown that link does not exist. And so, there is some risk, minimal risk to vaccine, but the benefits of vaccination far outweigh the risk.
Are all healthcare workers at OU Medicine required to be vaccinated?
Yes.
Just a quick follow-up to Dr. Kuhls. Some people say, well, we had the measles vaccine come along in, I think, 1963, and there was a dramatic drop in measles cases, but they'll attribute that to improved sanitation, hygiene, healthcare, that it really didn't have anything to do with the vaccine. What is your response to that?
Well, very quickly, the vaccine rates are dropping, and dropped especially in Europe, in Eastern European countries, and Now we're having imported cases and we're having outbreaks in the United States because our vaccination rates are lower. I think that's all you need to know.
Mr. Burns said, I think there's a belief that maybe there are too many vaccines. We require vaccination for kindergartners for 10 diseases, then we recommend others. And then if you want to go into child care, you're required to take additional immunizations. So there's a concern that there are just too many vaccines, they're too close together, they may contain chemicals, aluminum, mercury, and other things that could cause vaccine injury, as it's called. What's your response to that?
Well, so kind of two parts, and it kind of also ties into the previous question, just to kind of add in to also what the other speakers referenced. When we're talking about the benefits of vaccination from a public health standpoint, what we've seen over time from the 50s and 60s before vaccinations were available to now, we've seen for several diseases more than a 99% drop in the incidence of several of these diseases. Measles, for example, back in the 50s, more than 500,000 cases per year that were occurring in the United States, down to in some points, less than 100, and then now recently with outbreaks occurring in several other countries, we're seeing now more than 880 cases in 24 states, including a case recently identified in Oklahoma that was due to recent domestic and international travel to areas that was experiencing transmission of measles at the time that they traveled. So it's clearly demonstrated its benefits with the reduction in incidence of diseases. Regarding schedule, this is something that has been studied, in regards to safety, efficacy, and the spacing of these vaccines. Is something that's really well known in regards to how many vaccinations you get, in regards to whether it's a live vaccine or attenuated vaccine. And so, this is something that has been evaluated. There are mechanisms in place to identify adverse events to understand if there may be needs for reevaluation or modifications to schedule and recommendations based on specific age groups. And so, the general message is that, the standard schedule that is advised is one that is safe, effective, and recommended. But if individuals have questions or concerns regarding the schedule or specific underlying medical conditions that their child may have, then we certainly encourage those individuals to consult with their physician to answer those specific questions regarding the risks of any kind of underlying conditions or the specific questions they have regarding schedule.
Can I add a couple things? First of all, the reason why we have more shots is because we're preventing more diseases than we ever had before. And so it's not just adding shots to add shots. We are now preventing numerous diseases, which we've never been able to do before. Number two, I tell my patients, it would be nice if all I had to do is give a shot at 18 years of age and it protected you against all these diseases. But the reason why we give so many shots early on is because a lot of the diseases that we prevent most happen in very young children, 2-month-olds, 4-month-olds, 10-month-olds, 1-year-olds, young early childhood. So that we have to give all these shots very early on, and their immune systems, you need to booster that immune system to make it effective. So then the next thing you hear is, as you said, well, it's got all these components in it. Aluminum, I heard mercury, although mercury in early childhood disease there isn't any. There's some in multi-dose flu vaccines now, but there's no thimerosal in any of the childhood vaccines early on. And so the reason those have all been evaluated, there's been no data that says that they're dangerous. And our immune system gets sort of exposed to numerous thousands of things every day, and our immune system responds. So adding 10 more antigens or reactions is not going to overwhelm the immune system, which you also hear frequently.
There's been concern in Oklahoma that we have exemptions, 3 types: personal, religious, medical, and those the percentages have been climbing in the last several years. There's been concern in the medical community about it. Dr. White, do you think we should keep all of these exemptions, change anything about exemptions? What's your thought on that subject?
I mean, I think that there's evidence from around the world when you have declining vaccination rates, you have bad outcomes for patients. And so I think, it should be discussed what specific exemptions we have to try to keep those vaccinations rates high.
Mr. Burnside, what are the thoughts from the state epidemiologist on that?
So just a couple of points regarding this. When you're looking at the current measles outbreaks that are happening here in the United States, specifically Washington and New York, those are outbreaks that occurred because you had a person that may have traveled internationally to an area that was experiencing their own epidemic, becoming exposed, traveling back, and then developing illness and becoming infectious to others. These are states and specific communities that were affected because they had higher occurrences of exemptions, especially among younger individuals. Several of these outbreaks started or were really kind of amplified once there were individuals that were affected within child care facilities and schools that led to a higher number of individuals that were then infected and were not protected through vaccinations. And you're seeing this play out through multiple states. Those that may have less strict requirements and higher exemptions are ones that are dealing with problems with outbreaks. And in some states, such as New York, at this point still uncontrollable because of the level of susceptible individuals that continue to be exposed in specific settings. We recognize that this is a requirement in Oklahoma, that you have the ability to choose whether it be a medical exemption, religious, or philosophical. We feel that our role is that to really try to step up our role of educating the public in regards to making the right choice. From what we've seen from research, that's been conducted in regards to school vaccination policies, a more strict policy, of course, in place leads to higher vaccination rates within communities. That's definitely been proven. And then we're also seeing the fact that if you have lower vaccination coverage, that also leads to a greater occurrence of outbreaks of vaccine-preventable diseases. Of course, our role is in the framework that we have to try to get the information out there to help parents make the right choice and understand the importance of vaccination. Not only does it help protect your child, but it also helps protect others around you, especially more vulnerable members of the community, such as very young children, infants that cannot be vaccinated because they're too young, or individuals that may have underlying medical conditions that affect their immune status.
A quick follow-up. Is there any thought, are there any plans at the state health department, I know you can't speak for the whole department, to make it harder to get exemptions, especially the personal exemption, which is the majority of exemptions given, to make the process a little more difficult, to ask people to think about it more, if there's that belief in the community?
Well, there wasn't any legislation that was proposed to try to change the specific exemption allowances during this session, but we are certainly looking at mechanisms to help to provide more information to the public to help them make an informed decision in regards to their risk and their decision. That involves taking information such as kindergarten survey data, such as Oklahoma Watch recently published, and sharing that through our county health departments to schools and help them understand, are they aware of the number of exemptions or the number of children that may not be adequately vaccinated? Are there specific reasons why? Can we help them get information out to the parents? So we're looking at other mechanisms to try to boost the understanding of the evidence-based information in regards to the safety of vaccinations, the importance of protecting yourself and others in your community, and help individuals make their appropriate decision or an informed decision regarding their child and vaccinations.
Dr. Cools, there's personal rights at issue here, and it's a political issue in many ways. So you have a lot of tension up there, in state government over exemptions, over requirements for schools. What's your take on this dynamic that's going on?
Well, first of all, let me say that the exemptions obviously are going up in the state. There are beautiful studies that have been done showing that in states that have increasing exemptions, there's higher risk of having outbreaks of preventable disease. There's been studies showing that the policy that you have for exemptions in a state is related to the risk of having a disease. And so vaccine policy is very, very important. And as far as I see, because of our increase in exemptions, we have only 3 ways to go. We can do nothing, which is pretty much what the legislature, I think, is doing now in not really allowing anti-vaccine laws, not allowing anything to strengthen the vaccine laws. I think they want the problem to go away, because when you talk about parental rights versus public health, it's always a difficult argument, and especially for a politician. But if we do nothing, we're going to have outbreaks of diseases like we see in Washington, like we see in New York State. That's going to happen. The other end of the spectrum is we can remove personal and philosophical exemptions and make it mandated to vaccinate unless you have some medical reason why you can't have it. I will tell you that I don't think the state of Oklahoma, the legislature, is ready to do that. Senator Yen has tried to make the legislature aware in previous years that that needs to be done, and it's gone nowhere. And even in California, where now they have mandatory exemptions, what's happening is you basically have doctors getting paid to give exemptions, and so the medical exemption rates are going up. So it doesn't completely fix the problem. And then the third thing that you can do is the middle, is you can make it where at least the person who exempts from vaccine has to go through an educational process, has to go to their doctor to understand the benefits and the risk of immunization. Because we've made it really easy to get exemptions. This state is the easiest to get exemption in the country. You just have to pull it off of a website. It's not even a matter of all these patients getting exemptions are even anti-vaccine. I had a family that I took care of that came back to the state. They went to register at school, and when they registered at school, they told them that their hepatitis A vaccine was behind, and you can either go to your pediatrician to get the vaccine, or you can go to the link below, to the health department link, to get exemption form and sign it so that you can get in your kid and register for school right away. And if I'm a working parent and I'm busy, I'm going to go ahead to that link and I'm going to sign it, get it all done there, and I'll go in a few weeks and get my kid immunized, but then I stay busy and I don't get it. So the exemption rates going up isn't simply because of anti-vaccine people. In fact, there are a lot of vaccine hesitant people, and it's the process that we have. The number of true anti-vaccine people in this state are relatively small. And so I think if we're going to be number one in healthcare, as our governor has stated numerous times, we're going to have to do something to change the process.
Okay, thank you. I'd like to open it up to questions from the audience. Again, please ask a question. Keep it to about 30 seconds. We'll try to keep it moving as fast as we can. This gentleman over here.
Staying away from the politics of accepting a 9-to-1 match on money for Medicaid expansion, what is the perception of what it would do for vaccination rates of children if we did expand Medicaid? And do you know anything about states that have versus haven't and what their rates are?
Well,
You're directing that question to
Anybody?
Mr.
I have a feeling
Burnson?
since it's a Medicaid question, it's coming to me. But actually, the VFC program, the Vaccine for Children program, which is a federal program, allows vaccines for people who are on Medicaid and who are uninsured. And so in reality, expanding Medicaid should not really make a huge difference. However, when you look at the data for counties and you look at vaccine rates, there are a lot of rural counties that have very, very few exemptions and have very low immunization rates. So there's a huge disparity of health care, especially in our rural counties. And so there needs to be a lot of work of looking at the data that you have. Finally, you were able to show it to people. I'm happy about that. And to go out and to go to those counties and start working to get all the kids immunized. And there's caravans, there's a ways to do it, but we're just starting to work on that now in discussions with the health department.
Thank you.
If I could just quickly add, I think it's a great point, and I agree. We're taking recently we've been taking a different look in regards to the data that we have and using that, putting that data into action. So recently we've been more than willing to release our kindergarten survey data from 2017-18 school year that was collected last year, and we're finalizing the reports for this year's kindergarten survey data, and we'll be planning on posting that information on our website and making it just freely available, school-specific data. And this is information that we are putting out through county health departments and sharing back to the schools and helping them understand what are the vaccination levels for this specific grade cohort for your school compared to the rest of the state. And what are the strategies that the county health department might be able to partner with you to understand some of the challenges in regards to, like Dr. Cools mentioned, in regards to the convenience of maybe making the choice of quickly just filling out an exemption form instead of having to try to find an appropriate location. Another point, just to kind of quickly add, fortunately, in the current proposed budget, we're seeing an increase in allocation of approximately $2.5 million, if I remember correctly, specifically earmarked for vaccinations through county health departments in the state budget, and that's not been available for several years now. And so we see it as a great opportunity, and we appreciate that the governor has put that into the budget for us. That will help us to maybe fill in the gaps for individuals that are maybe either uninsured or underinsured that may not have had easy access through other means to receive vaccinations.
Other questions? This gentleman over. Oh, go ahead.
Oh, okay.
Yeah, we don't give up the mic.
This will be a question for, I guess, the health department. Amongst the medical community, and Dr. Cools mentioned Haemophilus influenza type B, which for those of you who don't know, that is a bacterial infection. It has nothing to do with the flu that we have a vaccine for. But amongst the medical community, I've heard a rumor that this year there was a 10-month-old of anti-vaccination parents who contracted Haemophilus influenza type B meningitis, and that child now has neurologic deficits. And I was just wondering, is that really true?
Well, because of confidentiality, it's difficult for us to discuss specifics, in regards to, details of the case that you're referencing. Did we have a Hib invasive disease case involving an infant? Yes, we did. So that is a recent case, and that is very unusual. That is unheard of for years. Hib is one of the Haemophilus influenza invasive disease type B. It's one of those that, with availability of vaccination, we saw more than a 99% reduction in occurrence of invasive disease among children less than 5. It is one of those that is clearly identified as a success of vaccination, and for years we did not have, an occurrence of a case involving a child less than 5, and so yes, we did have a case involving that age group. As far as the specific details, wouldn't be able to discuss the specifics.
Is that vaccination required for kindergartners? That's not one of them.
That's because it really protects children that are very, very young, and by age 4 to 5 you don't see H flu disease. Right. But that's a vaccine required for daycares, and those kind of things. But it's not one of the listed for kindergarten, especially because you're out of the danger.
Okay. Other questions? There's a couple of questions over on this side. This woman there.
So my question really revolves around the safety. So in March, the CDC stated that anyone that has a parent or sibling with a history of immune system problems should avoid the MMR vaccine. Does this include every autoimmune disorder, or what can you tell me about immune system problems where they should avoid the MMR vaccine?
Children that have severely immunocompromised problems or congenital immunodeficiencies or under chemotherapy shouldn't receive the MMR at that time, because those are live viruses. And so the answer is, in that situation, that's why the recommendation is like that.
The second part of that is that, so it also, in that same statement from the CDC, it said that you should not receive the MMR vaccine if you've received any vaccines within 4 weeks. So why is the MMR lumped if they shouldn't get that? Why is it lumped often with Tdap and varicella and all of that?
There's some data that shows that once you receive the MMR, that may slightly decrease your immune response to some of the other vaccines for a while. And so if you get the MMR, you should hold off on giving other vaccinations for that time period to make it fully work. Nobody's ever shown that there's a clinical difference, but when you look at antibody response, there's a slight decrease when you give the MMR.
2 rows back, a woman wanted to ask a question on the end.
That was similar to what I was going to ask, but I would go further from that and say, are there plans to do more detailed analysis of, like the situation that the other gentleman mentioned on the H flu, being a parent of an immunocompromised child? I know sometimes people in the clinical setting will make assumptions that you might be an anti-vaxxer versus immunocompromised. And as we take on this war more and more, how are we going to make sure that we're not making assumptions and do a real detailed analysis, because that causes injury to families, injury to the relationship with patients and doctors?
Mr. Burnside?
So I think it's a great question. And, one of the key roles of public health is to utilize our data to inform everybody regarding the risk, the occurrence of specific conditions within our communities. And so I think it's a great point. And when we're talking about disease occurrence, specific cases that are occurring, that is something that we are looking at as far as trying to find opportunities to utilize that data more to inform, whether it be the general public or it be specific individuals such as our healthcare provider partners that have the role of being on the front lines of educating parents, because they're the ones that are seeing them in the clinics, whether it be through our county health department clinics, but also private clinics as well. And then the same thing with our vaccination numbers, such as our annual kindergarten survey, utilizing that data to help us understand where are pockets of under-immunized populations within the state, and utilize that to maybe kind of target messages and to help understand why individuals are choosing not to vaccinate, and to utilize that to also maybe help to craft messages, educational resources that can be utilized by physicians to help inform their clients in regards to the choice that they're making in regards to vaccination.
In families that I take care of who have medical exemptions, who have immunodeficiency, when they go to the school, the rest of the children don't need to know who's exempted and who's not. But that's knowing that if I have a child that can't have vaccines, I want to feel comfortable that all the other children at that school is vaccinated. So that's why it's important that the health department starts using their data to do data analysis to figure out the schools that are low and make sure that those school districts understand the importance of getting everybody vaccinated for your child that can't be vaccinated.
I just want to follow up with, Mr. Burns said, I've noticed that no school is required to report their vaccination rates, correct? Why is that?
Well, it's not a state mandate. Some states have gone the route of requiring participation in specific statewide surveys. We're not one of those that requires this. So it is a voluntary process. We put in a lot of effort to approach schools and make this a several-month process where we send out notifications in advance that this survey is coming forward, sending them the instructions, and even offer assistance by offering to review their records and maybe help aggregate the data for them to understand the occurrence of vaccination or exemption status of children enrolled in their school. We're talking about a process that involves more than 50,000 children that are enrolled throughout the state, both in public and private and charter schools. So it is a very intensive process that occurs, but currently is not mandated. It is a voluntary survey. Most states it is a voluntary process. We also have a challenge right now where we do not have a mandated reporting process for vaccinations that are provided through healthcare facilities. If you go to a private physician, they may decide, if they're not at least a VFC provider or Vaccines for Children provider, they may decide not to report or submit vaccinations that are provided by students. And so it's not a full population-based registry, which is also a challenge when we're talking about analysis and understanding potentially pockets of under undervaccinated communities if we don't have a full picture regarding vaccination rates among other age groups that are not surveyed on a regular basis.
Well, what do superintendents or principals in these districts say that refuse to provide vaccination data? I mean, what's their explanation?
Well, so for the last 2 years, I can say being directly involved in the process, we've been able to achieve approximately 90% response, which is really good. So we're hitting essentially a census, meaning that this data can be used to generalize the occurrence statewide, but that does lead to challenges if we have specific communities or schools within certain counties where we may have multiple that do not respond. That can lead to a gap there in understanding the coverage rates within specific county or specific school jurisdiction, of course. Some of the reasons I may provide it may be that the time that it takes for staff to compile the records and aggregate the data on their own time with other competing interests may be specific reasons. Others may be that the concerns of how the data may be utilized, which we of course educate and inform that this is information that is going to be helpful to help drive action in helping them understand their coverage rates within their schools. But it is one of those, as obviously with this forum, you can see it's a very difficult topic, and it's one that can be somewhat controversial even for school officials in understanding how their data is utilized by public health. So those are just a couple of reasons that might be provided for a school to decide not to participate.
We've all agreed so much, I'll disagree with you a little, make it a little more fun. To me, 90% is bad because we have 10% of schools out there that aren't reporting their exemptions. If I was a school superintendent and I had a lot of exemptions or a lot of kids not immunized, I'm not going to report my data. If I was a superintendent and I had great vaccination rates and 0 exemptions, I'm going to report it. So I especially worry about that 10%. Number 2, private schools, 60% rate of reporting or something like that? 57?
About 57% last year.
We
yes.
have half the private schools in the state have reported to the health department their vaccine rates. We have no idea. On top of that, we don't know anything about homeschooled people. You say, well, they're scattered, so they're not clustered and they won't cause a problem. But my experience with all my homeschool families that I took care of, now they go to co-ops once or twice a week for physical education or for classes, and so it makes a difference. In that vein, twice now, one by Senator Griffin and this past year by Senator McCourtney, there was a bill that required all the school districts, public school districts, to go ahead and to mandate that they send their data to the health department. Both times it got through the Senate, this year just barely, but House leadership never put it to committee or heard it on the floor, so it's sad.
Well, let me ask, is some of this due to a lack of trust of the healthcare industry? I mean, we've had a lot of fraud that's occurred through different companies. We've had doctors who are paid by pharmaceutical companies to dispense certain drugs. Isn't this reflect kind of this distrust of some of the community, the healthcare industry?
In a way it is, and I'll just quickly also respond to Dr. Kuhl's comment there. I agree. I'm glad he called it out. I tend to try to make a positive view here and highlight our efforts to try to get up to 90% response rate, but it could be better. And you bring up a great point. We had a much lower response rate when it came to private schools, with only about 57% that have responded to the survey. That definitely could have been better. And so it is a challenge, and it's definitely a gap in regards to the completeness of the data. From an epidemiologic standpoint, 90% overall of the student cohort is considered a census, but there is that challenge with interpretation, especially when you get down to county level data or census tract level data if you have multiple school jurisdictions and 1 or 2 did not respond to the survey. So definitely points I agree with, and so I'm glad you called that out. In regards to the concerns with how the data could be utilized, I do agree. I think that's a point. It's questions that we receive over the last several years when school officials respond back to us and say, I'm not sure that I want to participate in this survey, or I really have other competing interests, and I just don't see this as a priority for what you're going to utilize the data. And I think our actions are going to help to address that. If they see the data being utilized more publicly, we put it out there, help with the interpretation, help use this information to guide their practice in interacting with parents that are enrolled at their school, then we might really kind of build more of a trust with those school officials and understand how this data can be utilized to help improve their vaccination rates and improve the overall health and wellness of their community when we're talking about vaccine-preventable diseases.
Thank you. Other questions out there? This, down the center aisle. On the left.
Okay. I have a question. I have a daughter who medical doctors admit today was hurt by vaccines, by multiple sets of vaccines. It wasn't just one. It happened with her hepatitis B, and she for sure had an allergic reaction to her MMR and that kind of thing. And I think what I'm wondering at this point, I have a couple questions, but my main question for you guys is there seems to be a lot of focus on the vaccination rates of children. When I look at the vaccination rates, according to the CDC, when I was growing up and in school, it was about 50 to 65% of children were vaccinated according to the schedule for things like MMR and school-required vaccines. Today, it's over 90%. But it seems like the biggest area of low vaccination rates is amongst adults. They're about 30 years and older. And my question is, why are we focusing so much on children when vaccination rates are as high as they've ever been, really? And we're not focusing on adults who are just as susceptible of spreading these, conditions as anybody else.
Dr. White, I'd like to ask you to address that first. You probably see a lot of patients, maybe ask even adults whether they're vaccinated.
Yeah, I think it is still a problem with adults. Some flu seasons we have over 80,000 people that die of influenza, and we've got a vaccine that works for it. We have a vaccine against pneumococcal disease. We have a vaccine against varicella zoster. And, it's just not, because there's not a mechanism with, kindergarten enrollment to increase that vaccination rate. But it's definitely something that's important as someone who has cared for patients who have, in the past who have had bad outcomes related to influenza. Vaccination for adults is a very important topic.
You want to say something? Well, I think the reason for the MMR and really concentrating on young children is because the complication rates for measles, the death rate, the pneumonia rate, the real encephalitis, the complications for that disease really happen in young children. However, I agree with you totally that in the United States, not just in Oklahoma, but in the United States, the medical community has done a very poor job in terms of adults and in adult immunizations. And I think part of that has to do with training. I think pediatricians, we spend a lot of time learning in medical school and in our training about vaccines, and vaccines are part of what we do. In internal medicine people, there isn't. And so I think the mentality has to change, and there needs to be a lot more focus on adults. There's no doubt I agree with that.
We got a question over here.
Yes, I have a question about, as we talk about the uptake of vaccines, I have a question about your thoughts about the possibility of providing liability on vaccine injury. We're saying that the risk is so low. I've even heard stats of 1 in a million. So are we talking about in the state of Oklahoma making the state liable should that rare injury take place? I know we have a national compensation program that's paid out for over $4 billion. And I work very closely with that program, and that program is failing our children. About 90% of that program right now is paying adults at this point. It's not really compensating the children that are trying to apply for the program because it's so overrun with adults, mainly to the flu vaccine. I want to get your thoughts on, would you be willing to address that more in the public? We hear very little about liability. This is the only product that you cannot sue the manufacturer or the doctor. So I would think that that would restore public trust from the parents that might be opting out. What are your thoughts on restoring liability in the state of Oklahoma?
Mr. Burnside?
Yeah, I got to say, I'm not very familiar with that process, and if that should be something to be considered, that would be something I would have to take back to our public health leadership for further discussion. So yeah, I wish I could have a more solid answer for you. It's not something I've been involved in discussions recently or in my prior experience.
It's not going to happen because there's already a federal national program. And yes, they paid out $4 billion. There's no doubt about that. But as you know, about probably way over half, probably around 2/3 of those are all mostly shots that were given poorly, causing nerve damages in the arms and those kind of things. And so that the amount of compensation there has to be proven that it was done to the vaccine, and the vaccines are relatively safe, and so that's why you don't see that many cases. But you're not going to see Oklahoma become liable because there's already a federal plan for compensation.
Question in the back. That gentleman has had his hand up.
Yes. Why do children get hepatitis B shots when it's a sexually transmitted disease, and short of the mother being a carrier of that disease, there's really no way that child should be exposed to hepatitis B? And of course, if you give a shot, there's always, like you say, a small percentage of it could be dangerous. So why take that risk, and why take money out of the consumer's pocket?
Who wants to take that?
All right. First of all, you have to understand hepatitis B vaccine. Hepatitis B vaccine is one of the few vaccines that we have that is not a killed vaccine. It's not a vaccine that is live. It's a vaccine where the one protein, the surface antigen, is made in a yeast cell, purified, and then is given. So it's not even a virus. It's one protein that's given. And when you look at vaccine safety, the number one of the safest vaccines that there is the hepatitis B vaccine. So why do we give it at birth, okay? And the answer to that is because in a perfect world where we knew if the mother was a chronic carrier of the hepatitis B surface antigen, then you're probably right, we can wait. But the fact is that some pregnant women, after they were first tested in pregnancy, can develop hepatitis B. And number two, there can be women that are missed. And for that reason, if you are a carrier of or have an acute hepatitis B infection, if you give the vaccine at birth, you can cause that baby to not be a chronic carrier for the rest of life and have decreased or have an increased chance of having cancer or liver disease down in the future. And so the fact is it's a safe vaccine, and in the relatively small chance, but real, that in case you missed that somebody the mother's hepatitis B surface antigen, you actually prevent that baby from getting it for life.
And I'll just kind of quickly add, one of our public health programs is we have a perinatal hepatitis B coordinator, and one of their roles is to interact with healthcare providers to assist them with assuring that when you have a mother who at least knows their hepatitis B status, then there's a case management process to where that assures that that child is given their series of hepatitis B vaccinations, but also IG upon birth to reduce the risk of developing carrier status. So that is something that is a challenge, or it's a process, but one of the challenges is that oftentimes you may have women who are not involved in prenatal care, doesn't know their status. And so as Dr. Cools mentioned, this is a protective measure to reduce the risk of if they were infected during delivery, that you reduce the risk of chronic hepatitis B status.
Thank you. I'd like to jump to Dr. White real quick off vaccines and ask, OU Medical Center dealt with a case of Candida auris, a fungus, lots of concerns, but it raises a larger concern. how safe are people when they go to the hospital in terms of getting an infection? And what do hospitals do, and not just the OU Medical Center, what lengths do you go to try and to detect drug-resistant germs, to prevent diseases from spreading? What's happening?
Hospitals in general and OU Medical Center goes to lots of lengths to identify patients who have drug-resistant germs, to isolate those patients, to keep records of that germ, so when patients come back in, we can isolate them. There is risk associated with various procedures depending on what's done, but we do everything that we can to try to prevent and mitigate those risks and identify those germs as quickly as we can. We've brought in multiple new technologies that in our microbiology lab that help decrease the time to diagnosis of those infections.
What about the cleanup, and do you scrub the room? Are there new technologies or approaches to doing that?
There are lots of new fun technologies using robotics and ultraviolet light. At OU, bleach is our friend, and we use bleach a lot.
And a question for Mr. Burns said, when those cases happened in 2017, I think, I forgot the other date, 2018 perhaps, there was no notice given to the public. No one had any idea that this fungus was in those two healthcare facilities. And I'm not even sure they were sent out on the healthcare network, alert network. So why? Why not tell the public? Why not tell even the county health departments?
Sure, it's a good question. When it comes to public notification or even notification in general of who should receive specific information regarding our investigations, we essentially kind of weigh, is there a risk to the general public? Because we kind of have to weigh the potential for causing unnecessary concerns or kind of mass hysteria, for something novel like this. Public health has a role to initially investigate unusual emerging pathogens such as Candida auris. For example, the two cases that you referenced, we partnered with those healthcare facilities, to complete several steps of the investigation. One was to understand the potential source of infection for the patient involved. Second is to assist with evaluating infection control standards to see if there might have been a breakdown in any of the processes and procedures that were in place. Kind of an external perspective to assist on top of what the standard processes and personnel that are involved with the facility. Also conducting patient prevalence surveys. And what we mean by that is tracing the patient that has a specific infection as they are receiving care throughout the specific facility and identifying other patients that would have shared the same environment and swabbing them and looking to see if they might have colonization from a common exposure such as the same environment. From these investigations, what we found in these two particular cases that there was no additional patients that indicated colonization, meaning that there didn't seem to be any kind of further transmission within the patient environment. And there was no breakdown in infection control processes from the assessments that were conducted. And in one of the two cases, there was also environmental sampling to look to see if there was any kind of potential detection of the specific organism on any surfaces within the patient's environment, and all those came back negative. So there didn't seem to be a specific occurrence where there was a breakdown to where there could have been others infected. And so, the decision was made at that time to not put out anything publicly at that time because it seemed to be very focused on specific patients. The patients that were involved in those investigations, they were informed, and they were asked to participate in the investigation by having a sample collected to look at their infection status, if they were potentially exposed. So there was notification of a specific select group of individuals that could have been at risk of exposure, but from the investigations, there wasn't an indication that there was any kind of broader potential exposure to other patients that might have just briefly sought care to where there would have been a need to do any kind of mass notification. So it is something that we have to weigh with our investigations. Is there an action for the general public to inform them of specific measures that they should take, or is it just kind of for an FYI of what's going on?
Thank you. Any other questions out there? A number of them.
Hello. I wanted to ask why we can't get the same gold standard of experiments with vaccines with the double-blind placebos? And also, are there any studies of vaxxed children against unvaxxed children?
I can take the first part of that.
I think the question was
So
why
the question, I believe, was revolving around placebo-controlled trials for vaccinations. Any research involving humans has to go through an investigational review board to make sure that that research is safe and ethical. And because of the vast benefits involved with vaccines, that kind of trial would not get through an investigational review board, just because the question would be, is it ethical to have a large group of unvaccinated patients?
Okay.
In saying that, though, to get a vaccine approved in this country and getting it recommended is incredibly hard. You have to provide, first of all, the FDA data of effectiveness. You have to provide data of safety. And then once the FDA finally goes through years of requiring stuff, then it gets approved. Then it's generally, that vaccine is not recommended. It has to go to the American College of Immunization Practices, run through the CDC, which is a large group of vaccine experts, and they are the people that make recommendations that should this vaccine be used across the country. After that, if it is then recommended and it starts to be used, then there's multiple systems that the CDC uses to look at vaccine safety. There's passive surveillance, the Vaccine Adverse Events System, VAERS. I have to get those words right because everybody just uses VAERS, in which anybody can report a side effect, and when you start seeing side effects pop up, then people will start looking into that. There's actually active surveillance. There's partnerships with the CDC and large healthcare providers like Kaiser, so that they can look real time to start seeing, hey, this vaccine seems to be associated with some kind of adverse effect. And on top of that, the CDC has also worked together with medical centers which have looked closely for adverse effects. So it's not just a passive system, and with each vaccine, we continue to have surveillance, so that it's a long-term process.
Thank you. We'll take one final question.
Yes, the National Childhood Vaccine Injury Act was passed in 1986. Our children, twins, were injured in 1988. We were not given a diagnosis of static encephalopathy until 1993. Why were our children's injuries not reported to us or the authorities? And further, why wasn't our grandson given a diagnosis of static encephalopathy after vaccination? Our son and daughter-in-law were not informed of these injuries, and his injuries were never reported in 2017.
Well, I would say it's hard to address individual circumstances and very heartbreaking ones. But I guess the general question would be, are there strong beliefs that vaccines cause injuries, and is the medical community blind to those possible causes?
That's what the National Vaccine Compensation Act and Board does. And I can't answer, I would like to answer your question, but I can't because I don't know specifics about that. And so anything I say is just hypothesis, which is not what we need to do here. So I can't answer your question.
We didn't have the internet back then, and we didn't have any ability to find out about the act even existed, much less on how to file or how to find out how to protect our kids from further injury, which they were further injured.
Thank you. With that, we will wrap up the forum. Thank you very much. Please give our panelists a round of applause for taking their time.